Go.
Good evening, everyone, our fellows, colleagues, professors. Welcome to the valvular heart disease webinars of the Continuous Medical Education channel. Today, we have an exceptional webinar discussing the infective endocarditis. And with this exceptional webinar, we have exceptional moderators and speaker, Professor Dr. Hussein Riz, Professor of Cardiology, Cairo University, is considered our father, our mentor, and our great professor, and one of the references of infective endocarditis and the medicine of cardiology entirely in Egypt. Along with Professor Dr. Karim Saeed, Professor of Cardiovascular Medicine, Cairo University, is considered our elder brother and one of our mentors and a great professor of cardiology. And we will have an exceptional speaker speaking about two interesting cases of infective endocarditis. Professor Dr. Marwa Mashal, Assistant Professor of Cardiovascular Medicine, Cairo University, and one of the greatest professors that treats infective endocarditis with large experience in this field. I hope you enjoy this webinar. And now we will share the screen of Dr. Marwa Mashal to begin the webinar, enjoying the moderation of Professor Dr. Hussein Riz and Professor Dr. Karim Saeed. Dr. Marwa, you may share your screen, please.
Okay, thank you, Dr. Haitham, and thank you so much for the introduction. Now I'm gonna share with you the cases we are going to introduce. We will have two cases. The first one is about the tricuspid valve infective endocarditis, an entity which we are meeting so frequently these days. Our patient is a 26-year-old man. He's a manual worker, cigarette smoker, and known to have a history of intravenous drug abuse. He's complaining of fever for 3 months duration, associated with severe bony aches, shortness of breath and moderate effort, and productive cough. Now, at this stage, which is the very common that we can meet in IV drug abuser patients, should we consider the diagnosis of infective endocarditis as a remote possibility? Is it just possible but not the highest possibility? Should we start antibiotic treatment for the chest infection? Notice that the patient is having productive cough, shortness of breath, and fever. Now, let's know that the tricuspid valve infective endocarditis is very common in intravenous drug patients. It's the most common presentation to find your patient with fever, malaise, and manifestation of systemic bacteremia, multiple pulmonary septic emboli with chest infection manifestation. Nowadays, this picture of the CT and fever is commonly misdiagnosed as COVID syndrome. And recently we have seen multiple patients with the diagnosis of COVID. So when you are meeting a patient with a history of intravenous drug abuse, chest manifestation, multiple septic pulmonary emboli, or multiple areas of blood ground appearance, don't forget to consider the diagnosis of tricuspid valve endocarditis. Bedside transthoracic echo was done, and the patient was diagnosed as tricuspid valve infective endocarditis. He had no history of chest pain, no dizziness, nor syncope, no lower limb edema or abdominal distension. Note that these features are very crucial to be looked for, the chest pain, because many of these patients have pleuritic chest pain that sometimes is associated with empyema. The patient has no history of dizziness or syncope, because in some patients still we are having active DVT, infected DVT that would present a great risk for recurrent embolization and pulmonary embolization that might risk the patient's life, and it will need specific treatment. Also, the lower limb edema might reflect the diagnosis of right side heart failure or the DVT. His clinical examination revealed the patient with pallor, but he was fully conscious, well oriented to time, place, and persons. He was lying flat, comfortably in bed, relatively comfortable. Blood pressure was 130/70. Pulse was 120 beats per minute, regular, equal of both sides, with intact peripheral pulsation. His neck veins was not that much congested, with systolic expansion, respiratory rate 30 per minute, and temperature of 39.5 most of the time. His apex was seen and felt in the left fifth intercostal space, mid-clavicular line, localized with systolic expansion, meaning it's still the left-sided apex. The right side did not overtake the apex yet. He had normal S1, accentuated pulmonary component of the second heart sound, pansystolic murmur heard over the lower sternal edge, reflecting tricuspid valve regurgitation. These are his investigations. Now you can see that the TLC was remarkably elevated, mainly polymorph nuclear leukocytosis with shift to the left. His platelet count was relatively low. Creatinine was 1.7. Liver enzymes were elevated. He had anemia too, and he had hypoalbuminemia of 2.4. His C-reactive protein was 270 milligram per liter. This is his EPG, pH 7.5, reflecting alkalosis. It was mixed alkalosis due to the dehydration and low CVP. Notes that the patient had severe tricuspid regurg with a normal GVP, and he was extremely hypoalbuminemic with no edema, so the patient was hypovolemic. His PO2 was 65, reflecting distress because of the lung parenchyma affection, and because of the alkalotic stage. His saturation was 85% on the room air, and carbon dioxide level was 35 millimeter mercury. How should we proceed? To start immediate empirical therapy, should we withdraw blood culture first? Should we withdraw full sets of blood culture? How should we proceed? Positive blood cultures remain the cornerstone for the diagnosis of the causative organisms and for the diagnosis of the syndrome of infective endocarditis. It provides live bacteria for both identification of the organism, tested susceptibility of the organism, which reflects which means more successful management with medical treatment and less need for surgical intervention. At least 3 to 4 sets of blood cultures should be taken at 30-minute intervals. Each should contain 10 millimeters of blood and should be incubated in both aerobic and anaerobic media. Regularly, 3 sets are taken over 12 to 24 hours. For critically ill patients, we withdraw 4 cultures over 1 to 2 hours. So we have time to take blood cultures for our patient before the start of the empirical antibiotic therapy. This is a picture of his transthoracic echo showing this very large vegetation. He had actually 2 vegetations that were attached to the septal and anterior tricuspid leaflet associated with severe tricuspid regurg. He had dilated right ventricle, but with preserved systolic function. The FC was 3.1. He had moderate tricuspid regurg, and his estimated pulmonary artery pressure was 33 millimeter mercury. Do we need to send the patient for urgent surgery? Should we give antibiotics for a few days, then send him for surgery? Should we give him full chance for medical treatment? Given the high recurrence rate of infective endocarditis in intravenous drug abuse and the relapse of recurrent drug abuse in these patients, surgery should be generally avoided and prohibited if we can. Surgery would be indicated only if we have right-side heart failure secondary to severe tricuspid regurg with poor response to the diuretic therapy. So we have to start the trial with diuretic therapy first. if we are having infective endocarditis that caused by microorganisms that are known to be highly resistant and difficult to treat with antibiotic, like fungal infection, or that antibiotics are not giving good response after 7 days. Tricuspid valve vegetation of 20 millimeter that persist after recurrent pulmonary embolism. So we don't have we don't take the absolute number of 20 millimeter as an indication for surgery. It has to be persistent after recurrent pulmonary emboli despite being on adequate antimicrobial therapy. In our case, the patient had recurrent septic pulmonary emboli, but these were not associated with the proper antimicrobial therapy. They preceded the proper treatment. So we are going to count from 0. What choice of the antibiotic should we give?
Dr. Marwa, I'm terribly sorry.
Okay.
Dr. Marwa, can we raise the voice a little bit more?
Okay.
Okay. Some of us have hard time hearing you. Okay.
Okay.
Thank you so much.
You are welcome. Okay. If you look for the antibiotic choice, his blood culture showed growth of MRSA, methicillin-resistant Staph aureus. It was sensitive to vancomycin, Zyvox, linezolid, gentamicin, amikacin, ciprofloxacin, sulfa, and clindamycin. Which antibiotic should we choose? Linezolid, as the patient has renal impairment. Vancomycin alone, as the patient has community-acquired Staph aureus or native valve. Vancomycin combined with aminoglycosides or quinolone. Now, let us know that glycopeptides, the vancomycin or teicoplanin or daptomycin comes next, are the agents of choice for MRSA. But we have to know that daptomycin needs to be administered in very large doses and combined with other antibiotics. And unfortunately, up till now, we don't have the choice of daptomycin in Egypt, although it's expected to be there very soon, inshallah. Aminoglycosides are not indicated in native valve methicillin-sensitive Staph aureus infective endocarditis, but in complicated MRSA and in the presence of MRSA, and despite being on native valve infective endocarditis, combination of vancomycin associated with aminoglycosides or quinolone may be needed. The MIC level for the vancomycin has to be done. We have to know that MIC level of 1 to 2 millimeter, 1 to 2 is reflecting high response to the drug. In the between 2 to 4, now it was considered to be intermediately sensitive. Now it's considered to be resistant, and we have to shift for the linezolid.
I'm terribly sorry, Dr. Marwa. Can we clarify? Can we clarify what's the
MIC?
Can we have the MIC, please? Yes.
This is the minimal inhibitory concentration of the drug that's needed to inhibit the growth of the bacteria in the lab. And according to the value that it comes in micron, according to the value that comes, we classify the organisms either totally resistant, highly responsive or susceptible, or in the intermediate zone. It's of great importance to know that the MIC for vanco, because in some cases, despite apparently responsive to the vancomycin, Staph aureus can be highly resistant. And it was found recently that for any MIC of 2 or more, it's better not to use the vancomycin. We shift to the Zyvox or the linezolid because it's the drug of choice here. As we don't get the proper response with vancomycin with an MIC of 2 or more. I hope this is clear enough.
Okay, thank you so much. Thank you so much.
Thank you, Dr. Haytham. Thank you. Okay, some facts that we need to know about the linezolid, especially with the more wide increased use of this drug as anti-staph and anti-gram positive. The molecule was originally invented as serotonin reuptake inhibitor and antidepressant. So the drug has the full criteria of serotonin reuptake inhibitor drugs. As an anti-staph effect against VRSA, was noticed, the drug was commercially released as a vancomycin-resistant staph aureus antibiotic. It's a reversible non-selective inhibitor of monoamine oxidase. Therefore, linezolid has the potential of interaction with any adrenergic and cholinergic drugs and serotonergic drugs as well, and with many of the opiates like betadine or synthetic opiates like tramadol. The main drawback is the very big list of drug-to-drug interaction. We have to know that the use of this drug in intensive care units is very serious because many of these patients are dependent on vasopressors, monoamine oxidase inhibitors. Some of them are taking serotonin reuptake inhibitors, particularly when we are dealing with intravenous drug abuser patient. We have to make sure that there is no history of recent use of tramadol or opiates, because this can cause serious drug-to-drug interaction. And it has interaction too with the insulin and other anti-diabetic drugs, and can carry the risk of hypoglycemia. It has interaction with the barbiturates, carbamazepines, phenytoin, rifampicin, and many other drugs. But the most serious is the serotonin reuptake syndrome that's associated with the monoamine oxidase inhibitors and some of the antidepressant serotonin reuptake inhibitors, betadine and tramadol. These can lead to deep coma and loss of the patient in many times. And the main drug side effects, as I told you, is serotonin syndrome, reuptake syndrome, and the bone marrow suppression. So the drug is not recommended to be used for a long time, ideally to be used for less than 2 weeks, and maximum duration should not exceed 4 weeks. And we have to notice that the drug is totally non-efficient against the gram-negative organisms.
Sorry, Marwa.
Now,
In many times, the platelet count does not allow you to even complete the 2 weeks.
Yes, that's true. That's very much true. Yes,
This
yes,
patient's baseline platelet count is 125.
20, which is not good. Yes, yes, yes.
I suspect if this patient takes linezolid, he will probably have to stop it in a week.
That's very much true. And in many patients of the infective endocarditis with the associated bone marrow suppression that the patient comes with, we are too much hesitant to use the drug Xivox or linezolid from the very early start. And in this particular patient, as the MIC was suggestive of good response to the vanco, it was less than 2, I wouldn't have choose the Xivox or the linezolid. And in many cases, as you mentioned, sir, we cannot go for the total complete 4 weeks. And for these patients, we do the so-called step-down management, where we step down from the Xivox or the linezolid to vancomycin in combination with aminoglycosides or quinolone to continue the full course of the antimicrobial therapy. I totally agree. I totally agree. Now, despite being on triple agent therapy, the patient received vancomycin, aminoglycoside, and quinolone. The fever was relatively controlled, but still the patient was feverish. Should we change the antibiotics? Should we send the patient for surgery? Should we look for complications? Now, this is his follow-up chest CT. Actually, in many times, the chest complications are the main cause of the fever or the relapsing fever. Sometimes the patient goes totally afebrile, then the fever relapses again. Now, if we can see this CT, you can see here the empyema on both sides. And despite being not in very large amount, this is like a mild to moderate collection, it can be responsible for the fever, persistent fever. In many of these patients, just drainage of this empyema would help so much to control the infection and will make you and help you to avoid sending your patient for non-indicated cardiothoracic surgery. Note that if you send the patient for tricuspid repair and the cause of the fever is the empyema, you will gain no response. And you have sent the patient with a history or a probability of relapsing endocarditis to go with prosthetic valve. This is not totally advisable. The patient continued on the antibiotic therapy. He showed improvement and he was discharged home. Thank you so much. Now, if any comment or any question regarding this case?
Can you show us again the echo, please?
Okay, unfortunately, I don't have the full loop echo, but I will show you the one I got. Just a second, please. This is the report. He had recursive valve endocarditis with two large masses, one attached to the anterior leaflet and another attached to the septal leaflet. It measured, this measures 2.4 multiplied by 2.1 and 3.1 multiplied by 2.5. And this is the echo loop that we have here in the presentation. Here you can find this very large mass moving in and out across the right ventricle inflow tract.
Yes. In patients without history of drug abuse, such a large vegetation would lead to a surgical decision. Problem here is the drug abuse, of course.
Yes, this is the main obstacle here. Actually, for a cost valve, I must have given the patient a few days of trial for medical treatment. If there is no recurrent embolization and the right ventricle is going okay with proper contractility, no deterioration generally or medically, I might consider being conservative. But for a dry cuspid valve infective endocarditis patient with drug abuse, I would go conservative as much as I can, because we have recurrent rate of the high, very, very high recurrent relapsing rate.
Yeah,
and
sure.
Another infection on top of prosthetic valve would be a hell.
This patient is particularly lucky because he ultimately responded to antimicrobial therapy and drainage, but I must say he was particularly lucky.
Yes. I agree.
Dear professors, can I have a question, please?
Yes, sure.
And the question is for you, Dr. Marwa, and of course for our professors, Dr. Hussein and Dr. Karim Saeed. Considering the curse of drug abuse in these patients, do you implement a course of rehabilitation for these patients to complement the treatment of infective endocarditis? Do you engage them into a rehab program, or at least recommend it in order not to have a recurrence, or not?
Yes, we do share the rehab program experience of Asr Al-Aini. We send these patients for the psychiatry department, the rehabilitation unit. We start the treatment or the management of drug abuse while being hospitalized. But unfortunately, and actually we make it as one of the prerequisites for our patients to continue the medical follow-up with the cardiology department and to have full follow-up echo and etc. We make it a prerequisite that they are highly committed to their rehabilitation program. But telling you the truth, unfortunately, more like 70% or more of these patients would drop the rehabilitation program, unfortunately.
Dr. Marwa, thank you for this nice case. I'm Karim Mahmoud. I'd like to ask you about how would you follow up this patient? I am talking about the clinical, laboratory, and echocardiographic follow-up and the frequency of this follow-up.
First visit for follow-up, unless we are having other indication, would be after 1 month. We would follow the right ventricular function in particular. We follow the TAPSE, the fractional area change, the dimensions of the right ventricle to detect any subtle deterioration before manifesting clinically. any progressive dilatation, loss of the contractility or regression of the contractility, back pressure or the liver detected as inferior vena cava congestion or intrahepatic radical congestion or increase in the size of the liver. All of these are indicators for to go for tracheostomy valve surgery. Repair would be the much preferable one, but sometimes total replacement. The regular follow-up visits, as I told you, first one is after 1 month, then 3 months, then 6 months, and regularly with each, we continue every 6 months follow-up.
What is our experience with tissue valve in these situations?
For tricuspid valve infective endocarditis patients, we use only tissue valve. We don't use mechanical valve.
No, I mean in drug abusers.
It's a bad experience, unfortunately, because most of them came back later on. I would tell 85% of those who underwent surgery were readmitted again with infective endocarditis over the tricuspid valve. And unfortunately, some of them were admitted twice, and they were sent for multiple surgery. The second surgery is a hell for the surgeon, and the perioperative course is a hell for the cardiologist. But the third time is fatal. It's fatal.
Yeah.
We didn't see any of them survive the third time, although we see like more than 10 patients with the third time, unfortunately.
Okay, thank you, Marwa. May I have some comments related to this interesting case?
Okay.
In your case, it is very representative of the problem of intravenous drug addicts and the risk of endocarditis that we are commonly seeing now in our department and in tertiary referral center. And I want to take this advantage to make some points that may be peculiar to the endocarditis related to the intravenous drug addicts. First, the diagnosis is not this straightforward in many cases. As you know, Duke's criteria was developed in patients with left side endocarditis. So Duke's criteria are not necessarily valid or of highly diagnostic usage in patients with right side endocarditis, especially with intravenous drug addicts. So we should have a high index of suspicion among these patients. When we have a patient with a refractory chest infection with evidence of marks in his arms related to intravenous drug abuse, we should think in endocarditis as a first possibility. Second, the microbiology in these patients is peculiar. It is an aggressive spectrum of microbes, staph, MRSA, gram-negatives, fungi, and the polymicrobial.
Yes.
And these patients present with a triad of right-sided heart failure, as in your case, and lung symptoms due to septic emboli. So CT is an integral early diagnostic tool that be used in all patients with suspected right side endocarditis related to intravenous drug addicts to look for abscesses or empyema, such in your case. And your patients already have evidence for sepsis, advanced sepsis with a low platelet count and the elevated serum creatinine. Also, we should investigate for the presence of viral infections such as hepatitis B and C and HIV as a routine in those patients.
It's incorporated in our work as a routine, I do agree.
Yes, yes. And also, right side endocarditis is a corner diagnosis in patients with intravenous drug addicts. Still, they have left side as well. 20% of patients with left side endocarditis are related to intravenous drug addicts. So these patients may have systemic embolization as well due to left side concomitant left side affection or due to paradoxical embolization through the patent foramen ovale.
Yes.
Yes. And we have difference in left side versus right side endocarditis in strategy of management. In right side, we wait, and we wait for a long period of time because the prognosis in right side is good.
Much better. Yes, it's much better.
Yes, it is better
and
than
the
the left
embolic
side.
event is usually contained.
Yes, and this may be related to the low oxygen saturation in the right side of the heart that may not allow the growth of bacteria to high grade in presence of effective antimicrobial. So we wait, and the surgery itself is not this good intervention because we implant valves not created for right side, and the risk of thrombosis is high, and the risk of recurrence is higher in patients with intravenous drug addicts. And the duration of antimicrobial in these patients without complication may be shorter than the left side endocarditis as well because they respond well. So as if we are having a different syndrome of right side endocarditis peculiar to those with intravenous drug addicts, and your case is very representative for many of these features. So these were some comments that may make some points clearer for our colleagues.
Very precious comment. Thank you, Dr. Karim.
One thing about daptomycin, when it becomes available, you know that it's not effective for the lung infection. It's deactivated by surfactant, and generally it is not recommended for right-sided endocarditis.
It's not the drug of choice for right-sided endocarditis.
Yeah,
I do agree. Yes, yes.
So we have a final question in this case. Is the difference regarding the management of intracardiac devices related to endocarditis?
Yes, yes. For the intracardiac device,
usually.
Okay, I'm with you.
Go ahead, Dr. Amaro. Go ahead.
Okay, it's usually a pacemaker lead. I assume you wanted to say so.
Yeah.
Yes, there is difference. Step number one is that you have to get rid of the infected device. You cannot give it a trial for medical treatment without removal of this device. The device itself will represent a permanent focus for the infection, and for that reason, we go removing that pacemaker lead or the assistant device if it's there. This is number one. Number two, if we are implanting the new device, while still we are having infection, we may consider the addition of rifampicin. Dealing with prosthetic valve infective endocarditis patients who have implanted valve within the media of infection. Number three, if we can go without reimplanting the permanent pacemaker again very soon, I mean, if the patient is not highly dependent on the pacemaker, we can wait until we are having a full course of 2 successful weeks of proper control of the infection at least, then we consider implantation of the new pacemaker. If the patient is highly dependent on the pacemaker, so we go for temporal pacemaker wire that can be implanted through transvenous access. We prefer in such condition subclavian or jugular, not the femoral, of course, because the patient will have it implanted for 2 to 3 weeks at least. Then we proceed for the permanent pacemaker.
Okay, thank you so much, Dr. Amaro, for.
Well, I just want to say one thing. Don't, whenever you can, don't resort to epicardial pacing because these leads fail very early.
Yes, they are totally unstable. I agree. صح.
Okay, so are we ready for the next case?
Yes, we can proceed for the next case.
Do anyone have any other comments? Okay, I think we can proceed to the next case, Dr. Amaro.
Okay, thank you, Dr. Haitham. Our next case is a complicated case of prosthetic valve infective endocarditis. Actually, this was one of the most challenging cases we have met in Asr Al Aini. 22-year-old gentleman. He's a driver, single, known to have a bicuspid aortic valve since early childhood. And he underwent an aortic valve replacement in September 2014 on top of symptomatic bicuspid aortic stenosis. 1 month later, the patient developed prosthetic valve infective endocarditis associated with aortic root abscess, dehiscence of the prosthesis, severe perivalvular regurgitation. It was associated with congestive heart failure, functional class 4. At this stage, should the patient undergo emergency surgery? Surgery is indicated, but it's not that emergency. You can wait a little. Should we start antibiotic course and control the infection first before referral to surgery? As the patient was referred to Asr Al-Aini Hospital, we decided to go for immediate valve surgery. The surgery was taken as urgent to emergency. The patient was referred for surgery within 3 days from admission to our hospital. We had to correct the INR was elevated. We had to go for getting ready for the blood and fresh neurons, etc. But if the patient was in worse situation of heart failure that was and intractable pulmonary edema or subacute pulmonary edema unresponsive to the medical treatment, we would have sent him for emergency surgery. A dehiscent valve associated with paravalvular leakage that's severe is not the case to be treated with medical control. And we don't wait till proper control of the infection medically because we don't have the luxury of time in such cases.
Do we have the echo at this stage?
Yes, I know not this stage, but later on. Yani, I will. Unfortunately, I don't have the movie echo for the patient in this stage, but I will show the coming stage. We have multiple events in these patients.
You know, I was concerned that this might be an aspergillus infection. That's why I was asking.
Yes, I know. And for sure you are having the whole right because we have, Sarah, because we have seen many patients with aspergillus infective endocarditis, unfortunately. Specifically when we are having para-aortic abscess or pseudoaneurysm. This raises the great possibility of fungal infection. But in these patients, the blood cultures and the valve cultures revealed Pseudomonas, which is a very bad organism with very high virulence and resistance to treatment.
Yes.
After surgery, the patient continued to receive imipenem and ciprofloxacin continuously for 6 weeks. That continued 6 weeks post-operative because the valve culture was positive. And post-operative transthoracic and transesophageal echo showed residual small cavity. We accepted such cavity because we know that the patient has been sent to surgery while in active infection, and we know that Pseudomonas is a very resistant organism that persisted, that we know for sure for a while after control of the medical treatment. But since the patient was totally afebrile and this small residual cavity had no effect hemodynamically, the patient was discharged with a plan of follow-up transthoracic and transesophageal at 1, 3, and 6 months follow-up plan. There was no evidence of relapsing infection during the follow-up. The patient didn't develop any fever. There was no rise of TLC or C-reactive protein or any inflammatory markers. By the way, these inflammatory markers in this peculiar case were followed up regularly with the echo for each visit he came to our department. He had no history of dyspnea, PNDs, or stopnea or lymphedema, or any manifestation reflecting hemodynamic intolerance of such cavity. Yet his follow-up echocardiography started to show rapid dilation of the aortic cavity in size with increase in the paravalvular regurgitation through which the patient was totally asymptomatic. As I told you before, he didn't give any history of relapsing infection or heart failure manifestation. This is his laboratory workup with the last visit, reflecting totally normal lab sheet. And this is his follow-up echo. At 6 months, his left ventricle in diastolic dimension was 6 centimeters. I have to tell you that this patient has entered the surgery with dilated ventricle, and we kept him on ACE inhibitors to preserve the left ventricular dimensions and contractility with beta blocker bisoprolol, trying to help the patient to reverse remodeling, the left ventricle to go for reversal of the remodeling. Left ventricle in systolic dimension was 3.4 and increased to 3.7. The ejection fraction was 73% and it dropped to 69%. And the cavity size started to increase from 3 times 3.9 to 3.7 times 3 times by 4.9. The prosthesis started to show more significant paravalvular regurgitation. Now, at this stage, should we consider the third redo? Surgery is still non-indicated because there is no manifestation clinically of heart failure or infection, and we should continue his follow-up. Should we start antibiotic treatment to control infection before referral to surgery if we are considering surgery? The patient was admitted to our department and we took a decision of second redo aortic valve surgery because despite having no manifestation of infection, no manifestation of heart failure, but what we have seen in echo was reflecting subtle heart failure manifestation with the drop of the ejection fraction and the risk of losing his proper contractility.
Dr. Marwa and Dr. Hussein and Dr. Karim, the question is, do we have any progressive parameters in the cavity or the residual cavity to mandate surgery? For example, if the cavity is increasing by point something centimeter, this will indicate surgery, or there is no such thing? What's the rate of progression of the residual cavity that could reflect that this patient might need another redo surgery? If there is any parameter?
You will find no data. Because these patients are not common enough. These are very rare cases. You will find no certain limit where you can judge that the cavity progression is indicative for surgery. But seriously, the patient here,
this patient
was ventricle.
This patient is a bicuspid aortic valve. And these patients have inherent weakness of proximal aortic tissue. So regardless of infection, I would expect some yielding of the tissues. And I mean, before sending this patient to the surgeon, what do I expect from the surgeon to do? Can you give me what do you suggest? Is he going to try to obliterate a cavity which is now approaching 4 centimeters? At the same time, he is replacing the valve for the second time. And if this tissue valve or repair or whatever is done, do you expect it is going to last with this kind of connective tissue?
I think he should go for Pental, and this time we have to replace the aortic root itself. If we apply even the rules of what should we do with bicuspid patient with progressive dilatation of the aorta, these patients should go for, because if he's now indicated for valve surgery, we are having severe paravalvular regurg that has secondary hemodynamic effect on the left ventricle. So the patient is indicated for surgery. We are going to replace the valve and we should replace the aortic root itself. It's going for progressive dilatation. As you mentioned, sir, this is a bicuspid aortic valve patient that we really expect more yielding of the tissues.
Yes.
If we're going to discuss the first option, should the patient have went such a surgery from the very early beginning, I would have said that the surgeon was a little hesitant to go so, because in the presence of severe infection, remarkably friable tissues, a surgeon would try to avoid more prosthetic material in the field and more sutures to be taken. Now, the patient was admitted for a second redo aortic valve surgery.
Dr. Marwa, may I have some
Yes.
comment or to interrupt you here?
Yes, please.
As you mentioned, we don't have evidence till now whether we have an ongoing infection or not, because this
Yes.
cavity may still be an infected tissue. Do you think PET can help?
Yes, very much.
Yes,
Yes,
this is a
yes,
point.
yes.
And the other, I think knowing the anatomy very well will dictate the type of the surgery, whether to go to a Pentel or to do freestyle with reimplantation of the coronaries. This need very good anatomical description before going to such surgery, especially if it is an infected tissues.
Yes. For this patient, unfortunately, we didn't go for the PET scan. It would have be of very, very, very great benefit and beneficial results to know are we dealing with severe infection, relapsing infection, no, yes or no, especially that the patient has come now after more than 6 months of surgery. We should not expect PET scan activity around the valve after 3 months. So I do agree with you that a PET scan would have been helpful to differentiate infection from only mechanical side effects.
Can we clarify more? Can we clarify more the role of PET? What the PET will show us and why?
Okay.
To clarify if there is an active infection or not.
Okay. Using radioactive labeled white PCs or PET scan CT, you can detect activity around the valve, because if you are having infection, certainly you will have clusters of the white PCs around the valve, and this will reflect that there is inflammatory infection. But within the first 3 months of the valve implantation, there is some inflammatory cells around the valve. So there may be some PET activity around the valve if you go for PET CT imaging. But again, after 3 months from implantation of a prosthetic valve, you should not expect to have radioactive activity around the valve. So PET scan has been added recently by the European guide, not that much recently, but in the most recent one, 2015. It has been added as one of the criteria for the diagnosis of infective endocarditis. It was added as one major to the new modification of the modified Duke's criteria they have done. PET scan activity around a prosthetic material after more than 3 months of implantation is one major criteria for having infection around this valve, and it's one major criteria for the diagnosis of infective endocarditis. In this patient, if we are having activity in the PET scan, this would have mean that there is residual infection, because we are seeing the patient now after 6 months of the implantation of the prosthetic valve. Hope it's clear?
Yes, very clear. Thank you so much.
Thank you, Dr. Haitham. This is his echo, transthoracic echo. Here you can find another third cavity between the aorta and the left atrium. That's it. This is the colored duplex here. You can find a flow going through this cavity. Okay. And again, this is F3. That's it again. It is the transesophageal. This is the mitral, this is the aortic processes, and this is the cavity compressing both the aorta proper and the left atrium. Dr. Karim Mahmoud, this is your echo if you'd like to comment or add any more valuable notes.
Thank you, Dr. Marwa. As
I
you
think
mentioned,
you can remember the patient very well.
Yeah, yeah, I remember him very well. As you
Mm.
mentioned, this is the commonest site for aortic root cavity, and this is actually a very large cavity at the posterior aspect of aortic valve, compressing actually the right atrium, and it has two openings. An
Yes.
exit with the left ventricular outflow tract causing a severe paravalvular leak, and an inlet with the aortic root. As you can appreciate, this is a communication with to and fro flow from the cavity into the aorta. If we, I
Yes.
believe if we place a pulsed wave Doppler at the exit at the LVOT, we can appreciate the to and fro flow, the characteristic of aortic pseudoaneurysm.
This is the three-dimensional echo. Hello, Karim.
We're hearing you, Dr. Amaro.
Okay. I saw the sound dropped out. This is again the cavity.
The three-dimensional echo gives a more detailed description of the aortic valve, and we can appreciate here how the cavity is going and compressing the left atrium, and the relation between the leaflet, the cavity, and the anterior mitral leaflet. I believe we have another image that showed clearly the opening, and yes, here this one. Here we can appreciate, as you can point with the arrow, Dr. Marwa. This is the defect and the opening between the cavity and the left ventricular outflow tract. Here we can see the rounded defect. This is actually a very large effect that causes the significant paravalvular leakage.
And this is his multi-slice CT. We looked for
To add a more comment, Dr. Morris, I'm very sorry.
Okay,
This is a pitfall of the transesophageal echocardiography. It cannot detect the distal extension of the aortic pseudoaneurysm, or aortic cavity. So if we have this very large cavity, the distal extension of the cavity we cannot be detected with the transesophageal echocardiography. So another imaging such as a CT or maybe magnetic resonance can help to detect the full description of the cavity and the distal extension of this cavity.
Okay. And it would help you to get oriented in relation to the coronary anatomy as well.
Yes, sure.
Okay, this is the inlet of the cavity, and as you can see, it's a huge one. This is the cavity. So the patient underwent the secondary aortic valve replacement with removal of the aortic valve, debridement of the annulus together with the abscess itself, reconstruction of the LVOT and the ascending aorta using a Dacron tube graft sutures proximally to the left ventricular outflow tract and the base of the anterior mitral leaflet, distally to the distal ascending aorta, excluding the whole cavity outside the circulation. The aortic valve prosthesis was implanted at a higher level than the anatomical aortic annulus because the area of the aortic true aortic annulus was remarkably disrupted by the infection. The left main trunk and the RCA were anastomosed using 8mm Dacron tube graft to the ascending aorta above the aortic valve prosthesis itself. We continued with regular follow-up with the patient with repeated transthoracic echo and transesophageal when needed. And during one of our follow-up after the second redo, we noticed again a small valve cavity, paravalvular cavity. The patient underwent cardiac MRI, so we can delineate better anatomy of the cavity and to detect its true extent. here is this small cavity. It's here again. It's small cavity. And this is the implanted coronaries here and here. We revised these images with the surgeon, and we did agree that the paravalvular cavity was very small, and the flow is coming mainly through the sutures. The cavity is stable in size; it's not increasing. We have been following him after the last redo now for 3.5 years. He's doing great, alhamdulillah, and we didn't send him for another 4th surgery. Thank you so much, and if any questions, please.
Thank you, Dr. Marwa. Dr. Hussein, dear professor, do you like to comment on this case?
So, thank you, Dr. Marwa. I'd like to ask you about, do you think that bicuspid aortic valve and aortopathy is contributing in the pathology we see in these patients, causing a weakness of the aortic media and significant aortic dilatation in this case?
Yes, I do agree. And as Dr. Hussein himself, sir, mentioned, and that yes, there is a great possibility that the nature of the disease and that the associated aortopathy have contributed so much to the problem of increasing in the size of the valve and the increase in the paravalvular leak. It was not true paravalvular leak, actually, as you have pointed, Dr. Karim. It came mainly through the pseudoaneurysm. If we look back again to the valve itself, it was steady in position, and there was no problem with the valve. The main problem came through the pseudoaneurysm. As you know, Dr. Karim, we have many patients in our series that who had paravalvular pseudoaneurysms and paravalvular leakage or regurgitant jets who continued for medical treatment and long-term follow-up now for years now, and they didn't need any intervention nor surgery, of course. There's a point I'd like to clarify here, that such paravalvular leak might be amenable for device intervention, but with this very large pseudoaneurysm and with this very large portal of communication, exit and exit, inlet and exit, I think no, we had to send him for surgery. But with another situation, if you are having no aortopathy, if you are having a smaller size defect, yes, we may truly consider the device intervention instead of sending the patient for the 3rd surgery.
Okay, just an argumental question. Do you prefer, when anticipating that this patient has a very weak connective tissue, to do from the start a complete aortic root replacement for these patients? I know this is a more complicated surgery, but if we are anticipating that this patient might have a cavity or a weak connective tissue surrounding the aorta, would it be better to do the 2nd surgery at the 1st time?
Yes, I do agree with you that it would have been wise to consider doing Pental from the very early stage, but I think it's a matter of benefit-risk ratio, and the surgeon is the one to judge intraoperative how is it, how would he go? If things were more more convenient for the surgeon to go safely for parental operation or replacing the root from the very early start, yes, I very much vote for doing so, particularly that we all know that the connective tissue disease and the nature of the aortopathy of the patient. But in this particular patient, he was not that much good going for surgery. He was in functional class 4. There was severe sepsis and the infection was not controlled. And the surgeon chose to go with the minimal prosthetic tissues or prosthetic material in the field.
Okay, Dr. Karim Saeed, I want to hear from you your comments about the case.
Really, I don't have many comments after this discussion. First, this case represents how challenging endocarditis management is. Endocarditis is a disease without cure. As you can see in this patient, he came out after the first surgery with what we think in a good state, but he developed something, and this is nearly the case in all endocarditis patients. They may have such aneurysm in their cerebral arteries and rupture later on, despite the fact that we are thinking it is a healed, cured syndrome. Endocarditis, once developed, the patients will suffer from the sequelae of this disease for years, even with a normal inflammatory marker. So these patients present one end of the spectrum of endocarditis cases. And Marwa discussed a controversial point. I want to hear from her in more detail about how to offer a conservative management for what looks like as a healed or inactive aortic root abscess, especially in presence of prosthesis. What is your experience in such entity?
We have some of our patients who developed the paravalvular aortic abscess, and knowing the sequelae of second or third redo in some of these patients, and since the patient has complete cure of the infection itself, we choose to manage these patients as mechanical lesion. So we start judging the situation mechanical regurg effect on the heart and on the patient's symptoms. If we are having completely free patients with no manifestation of heart failure, no mechanical secondary effect on the left ventricular function, and certainly no evidence of relapsing infection, we choose to go conservative with these patients. Because as I said before, and as in our case, sometimes it's the third redo. And it's like, I think, Dr. Karim Mahmoud, you may help me. We have been following like 10 to 12 cases of paravalvular aortic abscess who had complete cure of the infection and who had no sequelae mechanically of this paravalvular leakage. Actually, one of them, the paravalvular abscess underwent complete fibrosis, and it disappeared after 2 years with thickened fibrosis between the aorta and the mitral, and there's no residual defect there now. This is not the common, but in most cases we see the residual defect not increasing in size, not causing hemodynamic effect. The patient is not suffering from any manifestation of relapsing infection, so we go conservative.
So the rule for the aortic root abscess, especially in presence of prosthesis, is surgical intervention. However, we may have the option for conservative management for very selected individual when they have some well characterized features, as you mentioned in your case. And this patient didn't develop any conduction disorder during these 3 procedures.
No, luckily enough, No, his sinus, no.
Okay, very nice case.
Thank you, Dr. Karim.
Dr. Omar, one last question we faced yeah, frequently in the management of patients with endocarditis and aortic root abscess. When the patient is older, above 40 years, and the surgery is indicated, sometimes the surgeon demands a coronary angiography
Yes.
as a preoperative evaluation of this patient. So, what do you think about which patient we should do a preoperative evaluation, and when to choose not to go for coronary angiography or CT in this type of patients?
Okay, let's agree that you should help me more. You are the one who is more. You and Dr. Karim Saeed, you are the ones who are more specialized toward the coronary management, not me. But I have to tell you that in the guidelines of the management of infective endocarditis, it's class 3 to postpone patients from being sent for surgery just to do angiography. It's class 3.
Yes.
Particularly if we don't have any manifestation of coronary disease, why should we send the patient for coronary intervention, carrying the risk that one of the aortic valve vegetation may get hit by the catheter and embolize and causing the final end to your patient. Another problem is the use of multi-CT coronary angiography. Most of the time, it would require slowing down the heart rate of your patient. And most of these patients are having severe aortic regurg. You can't slow down the heart rate of a severe aortic regurg. This carries the risk of severe heart failure and actually cardiogenic shock, because they survive because of the tachycardia, not anything else. And in many cases, we go for the multi-slice CT not to visualize the coronary disk, but to visualize the relation between the coronary and the para-aortic tissues and the spread of the infection and the para-aortic root abscess to help the surgeon to have preliminary image. Is he going to go too close to one of the main coronaries? Yes or no, but not as a full coronary angiography. This would be very difficult to do.
Dr. Marwa, we are in a continuous medical education forum, and I want to make use of your presence here to ask some questions that may answer some controversial or some unrealistic thoughts in the mind of our colleagues. So, can we have a patient with endocarditis without a fever?
Yes, actually, yes.
Okay.
Let's say that most of the time the patient is feverish, but maybe 20% of the patients or 15% of the patients will be febrile. The most common cause of being afebrile is the prior use of antibiotics that can send the patient into a state of slow-growing organism, not causing severe fever.
No, let me remind you, Marwa, of another man whom we sent for valve replacement as an elective case with no endocarditis suspected, and it was Professor Said Aql who found the valve inflamed and sent it for Suhair Mahfouz.
Yes. It was Coxiella patients.
So we can have endocarditis not only without fever, but without any clinical manifestation.
This is true. It is true. And for this peculiar patient, he was a Coxiella patient, and this is the second common cause for having no fever. It's the zoonotic infection. Most of the zoonotic infections have very low grade fever or very subtle fever or sometimes febrile. Another Aspergillus or fungal infective endocarditis. Many of these patients are afebrile. And if you can remember, I think you definitely can recall it, sir, and Dr. Karim, that the study we have done on the fungal infective endocarditis, that being afebrile was one of, and we had large vegetation, with a combination of peculiar sign for infective endocarditis with fungal infection. So patients on long-term antibiotic, patients with zoonotic, patients with fungal infection, patients with renal failure, elderly patients, any case of immune compromised patient, any patient who's receiving immune suppressive medications or steroids, all these are prone to have infective endocarditis without being feverish.
Okay, another question in a firing question and answer mode. You started antibiotics for endocarditis patients and he responded well. What is the time interval you are expecting the fever will disappear?
Usually within 3 to 5 days, but the guidelines will give you a chance of 7 to 10 days before judging your antibiotics of being insufficient. But usually within the first 3 to 5 days,
so it is not. So it is not a prompt response for the antibiotic. Actually, rapid response for fever is again the diagnosis of endocarditis. And again, if the patient now is afebrile, then the fever reappeared again. What are the possibilities?
Okay, we have to search mainly in two directions: the paravalvular extension of the infection, the presence of aortic root abscess, the presence of intracardiac fistula, the spread of the infection toward another valve, or the distal the static infection foci. The most common is the splenic abscess. And sometimes we start with a very small splenic infarction. Sometimes even it's not visualized, and then the breakdown in the tissue of the spleen end up with a splenic abscess. This is one of the most common causes of relapsing fever in infective endocarditis patients. And in tricuspid valve, of course, it's the empyema that sometimes you get good response to the fever. Good response of the fever to the antibiotics, and then you start having fever again because of this collected empyema. And range of the empyema gives you very good response.
Two other causes: one, organism acquiring resistance to the antibiotic. This happens. And the second one is antibiotic-related fever, drug fever.
Yes. Okay. And the antibiotic-related fever is very common too. We see it, and it usually comes by the end of the treatment when you are almost finalizing the course, and then the patient is relapsing.
One should suspect drug fever if he finds one of two signs: eosinophilia or skin rash.
Yes, that's very true, sir. That's very true, sir.
Okay, another question. Now you have an endocarditis patient, and you have two options. The first option to start empirical antimicrobial right now, and the other is to start after having the culture and having a response from the lab that the culture is yielding. So you have two scenarios. In your experience, when to opt for each of these scenarios and for what type of patients?
Let me tell you that in almost in all of my patients, I wouldn't start antibiotics before getting even the first culture. For emergency situations, when you are having a severely septic patient, bending septic shock, continuous fever, very high TLC count, we start a very rapid antibiotic and on empirical basis. We withdraw cultures rapidly over 1 hour, and we start our antibiotics. Sometimes even after getting the first two culture on admission, and after half an hour, we start the antibiotic management, because in bending septic shock, the first hour is the so-called golden hour to improve your patient and prevent death. But even in these situations, I can get the first culture first. And it's important that we try always to get cultures before starting the antibiotics. And
okay, so the rule is to postpone the initiation of antimicrobial till you have a good cultures. Yes. And a signal from the lab it is positive, so you will know the organism. Otherwise, you will end with a culture negative endocarditis.
End with a culture negative, and let me tell you that proper identification and proper of the organism and proper choice of the culture-based antibiotic is very important to help you to go through successful medical therapy without the need for surgery.
Okay. Last question about outpatient management for endocarditis. Do you have such experience?
Very limited experience. It maybe because of the nature of our patients. We are a tertiary referral center where we receive most of the time highly complicated cases. So that's why it's difficult to choose patients of them to send for home-based therapy.
Okay, this is for a tertiary referral center, but
yes.
Are we allowed to manage some endocarditis patients at homes?
We are allowed to manage some of the patients at homes, but as per the European guidelines, this will require infective endocarditis team management.
Yes.
The patient has to be linked to an infective endocarditis team. The patient has to be highly committed to the regular visits for follow-up. It has to be once or at least once or 2-3 times per week follow-up visits with regular follow-up of the labs, with regular follow-up of the clinical situation of the patient. And it's mostly indicated for those patients who are non-complicated.
Yes, non-complicated with non-virulent microorganism.
Yes.
Dr. Haseres, do you have any comment upon these points?
No, regarding outpatient antibiotic treatment, the recommendations are, as you and Marwa said, some susceptible organism, and the patient showing early response in hospital, and the kind of patient who is compliant with follow-up visits, and the presence of an endocarditis team, which is ready to readmit the patient at once if something happens.
Yes.
Thank you, Maro. Thank you.
So much. Thank you so much.
So thank you so much dear professors, for this very interesting and enjoyable session. If you kindly can provide us with some wrap-up comments, Dr. Hussein, Professor Dr. Hussein.
Nice.
Dr. Hussein.
أنا سامعك. I have got nothing to add. These are very good cases, and the material presented today is laden with the information, and I have no further comments on this session.
Okay, thank you so much, dear professors. Thank you, Dr. Marwa, for these two very interesting cases. And see you next week, inshallah, at the CAC. Thank you so much.
Thank you so much. Thank you so much.